Hello, everybody.
Clinic exactly as Jim described it, where you have the person who had the chiropractor they've gone to for years, and they describe this exact story. And with them, they may come in with a manipulable lesion, but at that point that they need the rehabilitation portion, but also identifying what is the key trigger, what in their daily activities, their posture, their sleep, their repetitive movement, their movement strategy, which may be a primary driver on this. And then once you can identify that, then you get a much better job of unwinding it. And then you're in a blend between, are you looking at motor control exercises or hypertrophy training of the multifidi? You're looking at these other processes and rehabilitation things, which are then good on the back end. They've been shown, if they've done consistently, reduce these episodes by like as much as 80%.
Yeah, I think that's true. The key word there is do it consistently, and your problem is your patients pretty much won't do it. But you've got your job to do, and your job is to give them the exercise. It's their job to do it. If they fall down on the job, that's not your fault, basically. Second part, you mentioned first episodes of subluxation may be due to trauma. What factors are making you confident in manipulating this patient? Well, it's the same as it always is. Basically, you want to make sure it's safe to do so, and it's really not very different from stuff that's been going on for some time. You just got to make sure it's safe to do so. So you've got to worry about what the trauma has done to other tissues, such as fractures and so on. You've also got to worry about other factors, such as disc herniations, VBI, and all the other stuff. But once you've made sure that it's safe enough to do it, just go ahead and do it. The trigger, in this case, doesn't matter. It's not going to be repeated. The best you can do is say, don't get in another car accident. So the trigger's not going to be repeated. So it's really not about changing their activities and their lifestyle. Just don't get into another accident. So in some ways it's more difficult. What'll happen is that this will keep coming back. Motor vehicle accident problems keep coming back, same as all segmental dysfunctions do, and possibly this more than normal. Then you've got to look at whatever it is they're doing in their regular life that causes it to keep coming back. But the only difference is making sure that it's safe to manipulate them. But that applies to everybody anyway. Is that okay, Shannon?
Yes, thank you.
Or was you looking for something else?
I think just like what specific tests or anything that you would do to make sure that the patient is safe.
No, all the same stuff.
After
make sure they don't have a fracture, make sure they don't have VBI, and until you're happy with it, don't manipulate anybody with dizziness. It's all the same stuff. It is. It doesn't change just because it's their first episode.
That makes sense.
The only thing you haven't got is a history of having it manipulated over and over again and not having a problem with it. Okay. Marissa, makes sense, sounds good. Okay, what did I answer? I like the analogy about the sliding door. I do as well as it happens. I plan to use that with my patients. Is this your go-to explanations for patients as well? Do you have another way of explaining it? I tend to use the term stuck to the effect of this joint is stuck and we are planning to get it moving again. And yeah, I don't get into big anatomical stuff unless I'm asked for it. I don't get into analogies. I simply say that this joint's not moving as it should be moving. I'm going to try and get it moving for you. That's it. Now, if you're going to manipulate, you've got the issue of informed consent and everything else. But as far as explaining the effects of what I'm going to do to the patient, I try to make that as non-technical as possible. If they want more technical stuff, I'll give it to them. But that's not my first go-to thing.
Hi there. Hi there. Okay.
Now, you're not saying okay to my answer, so is that okay?
Yep, that makes sense.
Okay. Caleb. After watching the video, the biggest question I had, you distinguished between the facet and the unconvertible joint. I know you said to glide each one, I will tell you which is dysfunctional. So this is maybe a better question for the weekend. Of course it is, but I'm just going to say this to you. The difference between the glide of the facet joint and the U joint is 90 degrees. The glides of the facet joint are down the back of the neck, and the glides for the U joint are down the side of the neck. And that's your difference. And you'll be getting that. But basically, you push down the back or pull up from the back to get flexion and extension glides, and you push down on the side of the neck to get unconvertible joints. And if you want to look at anterior and posterior gliding of the unconvertible joint, you basically rotate the vertebra by grabbing the transverse processes and pulling them forwards and backwards. That's it. Okay, but it's actually 90 degrees. The difference between the two, the big difference between the two is 90 degrees of plane. It's a completely different plane.
It's similar to having one bowl stacked on top of the other bowl is the analogy they use. And those bowls slide on each other. These are upside down bowls because I can't do it the other way without standing up and contorting myself. So you think of that one upper bowl is kind of, well, if it's going to go this way, it slides in this manner. And that's the ancovertebral joint. You like that, Dylan? We have that on video too, so everyone can relive that wonderful moment.
You all right? This is Mark. Okay, well, pointless asking him how he feels. I won't be on the Zoom call tomorrow, but I'll check the recording. I frequently heard of scare tactics and verbiage chiropractors seem to use to convince patients they need chiro care, usually involving joints out of alignment, dramatic descriptions, etc. What does your patient education look like when discussing joint subluxation? Help them understand what is happening and why do you put it in different terms? Okay, well, I've already answered that one. Keep it as simple as you can, make it more complex if that's what they want and need. You don't have to get dramatic about this. I'm not sure that they always do. I think you've got to remember that their philosophy isn't entirely bad. If you really believe that you need prophylactic care to stop these things coming back, then you would be doing much the same as the chiropractors do. You would get them back in every 6 or 8 weeks to make sure the joints are moving normal. And if they weren't, then you'd make them move normal. I really don't have a problem with the chiropractors doing that. We don't do it because we consider it crass, or I don't really know why we don't do it, but it's not part of our culture. But there's nothing wrong with that. If your motto is if this needs to be prevented, which is our motto actually, then we should be asking them to come in for a check every now and then, rather than waiting for them to come back when it's painful. Because every time it's painful, you get inhibition of muscle, which can, the more often that happens, and the longer it happens for, the more likely is atrophy, not just hypotonicity, but atrophy of the stabilizing muscles. So I haven't got a problem with them doing that. And if I was going to do that, that's exactly what I would say to them. You need to come in, we need to catch this before the pain comes on, and we need to deal with it before you have muscular problems. That would actually be my spiel to them. And there's nothing to apologize in that. And unfortunately, Mark's not there. I'm not sure if that's what he was thinking. They're not going to die. There's nothing dramatic that's going to happen to them, but there you go. Does anybody see a problem with that argument? Ask them to come back in. No? But it's part of their culture. It's not. Yeah, Jenna, sorry.
I was just saying, like, I don't see a problem with that, but I think it's more because of insurance, like that we can't really do that in our actual profession.
Okay, then in that case, what I would argue is that we should be doing the checkup for free.
Wow.
Yeah, I mean, if this is your view on this, and they can't afford to come in and pay for it, or their insurance isn't paying for it, then you should be at least giving them a discount on that check. Not on next treatments, but on that checkup.
Yeah, now, do you have direct access where you are?
I was gonna say, yes, we're direct access, but we can't do like free assessments on like government payers. We can do it on Blue Cross Blue Shield, that kind, but not government payers or like work comp. We can't do that.
Well, in all honesty, you should. If this is what you believe. I don't do it. I'm not being holier than thou at all. I don't do it. But if this is what we believe, then that's what we should be offering. We don't, but that's really what we should be offering. We talk well, but we just don't follow up on it really. And it would actually bring in income. I hate to say that, but it would bring in income. Anyway, where are we now?
If you fix them with this in the short order of time, they're going to find their way back to you. That's what happens is I may see somebody 12 times in a year because I'm seeing them in 3 to 4 bout episodes. It's always not always explained to the mid-level administrators, but if you fix people and you make a dramatic difference right away with their buy-in, they come to you for other little things. So
yeah, you're trying to. I tell you what, Dave, don't get into this. I've tried to change company culture, and it doesn't work. It just comes back and bites you in the ass, and they know this. They know this. You haven't got a lot of choice, have you, guys? You're expected to see your patient a certain number of times. If it's not said explicitly, it's there implicitly, isn't it? No, I know it is actually. Don't worry, don't. It's not worth it, Dave. I tell you that it's just not worth it. Okay, this is Deb. Regarding assessment of the neck, I find it hard to identify each cervical segment. On many patients, it seems to blend together. Some segments are hard to palpate, others are easily identified. C2, C6, 7. Are there tricks? Yeah, don't palpate the spinous process. All right. The spinous processes are extremely inconstant. The reason the reason you can palpate C2 and C7 is because they're big. But C2 can actually overlap. Once it's got all the stuff on it, muscles and everything else, once it's got all that stuff on it, they can overlap 2 or 3 other spinous processes. And these things can be big or small, it doesn't really matter. Don't count spinous processes. You're going to count transverse processes and articular processes, which you can feel, and you can count your way around the neck that way. And you're going to be, I think, Dave, you're going to do flexion, extension, translation as the assessment tool. You're going to be using the transverse processes for the PPIVM, as it were, and you'll be using the articular processes for the PAVMs. So don't try and use the spinous process. It simply doesn't work. That's why you can't do it.
You think of the spinous process like a prone PA. It's a gross assessment tool.
Yeah, but you can't even feel it there. If you're going to do PAs, you do it on the transverse processes. You can't feel them.
Yeah.
Like, if you count spinous processes, you'll be lucky if you get 4 or 5.
Well, I mean, it's really looking for pain provocation. And then you end up going and doing other tests anyway.
No, she's trying to find her way around the neck. That's what she said. Some arguments are hard to palpate.
Okay.
She's trying to identify each one. So you don't do the spinous processes. I also have a question about cranial nerves. I've read that at least cranial nerve 4 and maybe 7 cross to opposite sides of the brain. Is there any clinical implication of this, or do clinics have ipsilateral implications? They all cross over. All of them do. A few of them, it is 2, 7, and 11, I think it is, have vascularization from their own side as well. In fact, with 2, you know this, the optic chiasm is a partial decussation. Let me see if I can draw this for you. Okay, so what we've got is this. If this is the retina there, you'll get fibers coming from the lateral side, fibers coming from the medial side, and those fibers cross over. I think they cross, well, they cross over at the nucleus, all of these do. So you get this sort of thing happening. So when you get past the chiasm, which is neurological now, as opposed to peripheral, central versus peripheral, you can see that what you've got is fibers coming from both eyes. And this is to spare the sight. Should you lose one eye, you'll still have visual cues coming in from both sides. And that's really what it's about. So these things do cross over, and there's no real implication except for me to say, if you're trying to identify their stroke, if the facial signs and the long track signs are on the same side, then it's above the, it's in the cerebrum. If they've crossed over, then basically it's the midbrain that's doing it. So they typically cross over at the nucleus. So above the nucleus, you may find that it's unilateral. Below the nucleus, so this is mixed. Okay. For example, if I have, sorry, it's the other way around. If I have the facial nerve affected and it's above the nucleus on the right side, some of the muscles will be spared. The muscles above the eye, I believe, are spared. The muscles below the eye are lost on the side of the infarct. But below that nucleus, all of it's gone. And the optic one, that's what you saw. Anything anterior to the chiasm is completely lost. Anything behind the chiasm is not. So you only get partial blindness if you lose one eye. Is that okay? There's no real implication for us. You really don't care what sort of stroke they're having, just that they're having a stroke.
Yeah. Uh-oh. Can you hear me okay?
Yeah.
So I guess the implication for positive cranial nerve testing is send them back to the neurologist or doctor. Okay.
Yeah, it depends. That depends on how it's going. If they've walked in and you found there's not trauma or anything else, and you found positive cranial nerve signs, it's either congenital or there's been an injury in their childhood, or they're in a disease state. This stuff doesn't have to go to the emergency room, really. You can send that back to their family doctor. If this is post-trauma, though, or if it only comes on intermittently when the symptoms are there, these are unstable things and they need to be seen by emergency.
Okay.
If you're not sure, send them all to the emergency room. It's not your job to be sure about this. Your job is just to not be sure about it and get it the hell out. Yeah. Fortunately, this doesn't happen too much. You're getting it overemphasized here because you need to have it overemphasized. Emily. All right. Can you expand on neurophysiological phenomena that would allow for a subluxation to occur? You can have this wrapped up really quickly by me, but I've also given you a link to, it's on there, is it? Did you see it, Dave?
Didn't see a link on the thing I copied.
Really?
Yeah.
All right. Who asked this question? Who was it? It was Emily, wasn't it? Yes, that was.
Yeah.
Emily, you got the link? Did I send you the link?
No, I don't think I emailed.
I did. I know I sent one of your links. I'm pretty sure it's you, Emily. All right, I'll send you another one. I'll send a synopsis of, or I'll send you a link to a synopsis I did of the Australian work on this way back. Essentially, this is a model that the Australians use, which I don't know is universal. It's not so universal as they say, but you end up getting, okay, if this is caused by trauma, if the trauma is bad enough, you'll get pain inhibition. If it goes on long enough, that pain inhibition will convert to reflex inhibition. Now, pain inhibition is straight from the pain. Any movement into the pain inhibits the muscle. If this is reflex inhibition, the reason you're getting that is because of inadequate proprioception. So if this starts with pain inhibition, you don't move very much. The pain proprioception goes down. It converts into reflex inhibition. So even when the pain's gone, you're left with the reflex inhibition. So you lose the stabilizing control that those muscles give you, and then you start going from an end zone instability, encouraging more and more to the end zone structures. You break them down and you have an end zone instability, and that's when the patient starts having problems. Maybe they may not get problems for this, but if they're going to see you, they're having problems for it, and that's when the end zone stuff starts. If the other, it can happen the other way. So if I have a hypomobility, for example, that is stressing out another joint, that will break down the end zone structures. Once the end zone structures are broken down, you start losing inhibition, start losing proprioception again. So then you get reflex inhibition loss. So it can go either way. It can start from the inside out, or I think probably more commonly, it'll start from the outside in. Now, the advantage of starting from the outside in is that you may be able to identify the stressor and do something with it. If it started from the inside out with pain, you can't do anything about the cause of that, as in the past. So one of them probably has a better prognosis than the other, providing they're going to exercise. Is that okay? But I'll send you the link again, one of you anyway, and you can read it. I think it's.
I do have it, Jim. I was going to send it out after today.
Okay, good. So that work was very good from the Australians. I think there was a lot of it that they're missing. There's stuff they're missing. There's stuff that they're expecting too much from. But I think the basic work on that was really quite good. And I think the synopsis is reasonably accurate. Okay.
It's also, you see it in like Jill Cook's work and other people's work. If you look at tendinopathy, it's where you really see this, where you see even like the cortical remapping. And I think that's similar when you're seeing this reflex inhibition in the tendinopathy patient, where you've done eccentrics, they get 80% better and then they get stuck, or they don't quite make it on. There's a bit of that inhibition, whether that's happening at the spinal cord level or also in the cortical level, and the ability of down drive and feed forward. So I think it's been kind of advanced a little bit, even in the overlapping mechanisms from cortical drive.
Yeah. Okay. Mike, can you identify the portion of the YouTube video when you mentioned you cannot be at fault? Which joint cannot be at fault for hypermobility? I'll do that in a minute. All right. You're the other. Somebody else asked me that. I'll do that. This is Kelsey. If you have a subluxed joint, what's DT? Kelsey, are you there? All right, I don't know what it means. If you have a subluxed joint, DT and instability, what's DT? Is there a time when you would not want to manipulate to preserve the new hyperstability? How will you be able to tell whether or not you should mobilize in that case? Okay, look, when a joint subluxes, this is the point I was trying to make. If you try and do stability testing on painful joints, the chances are it's going to end up being negative. If the joint sublux, then that joint is hyperstable. It's not moving, so it's hyperstable. Now the question is, do I manipulate that and return it to its unstable state? And the answer is yes. If they're coming to see me, that hyperstability, which is hypomobility, is likely to be stressing out other things. Certainly it's either painful or it's causing something else to be painful. So yeah, you do hit that. And then you try and do something about the instability that is laying there waiting for you anyway. But yeah, you do take that out. Okay. It's really as simple as that. And you may get problems. I'm involved in a malpractice case at the moment. Not mine, somebody else's. And it was interesting because what this guy did was grade 2 and 3 mobilizations. And while he was doing it, something clicked in the patient's neck and they had pain afterwards and it's ongoing. So the question was, did the treatment cause the pain? It triggered the pain. And should he have done it? Yeah, he came in for that problem. His job was to get it moving and there was no indication that what he was doing was wrong. And it was grade 2 and grade 3. Now you can argue that maybe the manipulation might have been a bit strong. She had a car accident. Tell me, how many of you would do this? This woman had a car accident 25 years earlier. How many of you would have gone back 25 years and taken a detailed history about that car accident? If the pain she's coming in with now isn't about that car accident. Would anybody have done that? Because I certainly wouldn't have done. So this is one of the things that the virtuous therapist who's giving information on the other side is wanting to do. This is really quite amazing how virtuous they get when they're doing this shit. I can't see anything he did wrong. And sometimes this stuff is unavoidable, and providing you're not negligent in what you're doing, he took the easiest and least stressful way of treating her neck. And as soon as it started to get painful, he changed even that and he moved to needling. So the fact that it clicked, and actually there was a radiologist who said, you have to manipulate a joint to click it, and that's complete bullshit, absolute crap. You can have a click when you're setting up, In fact, often you do. So because the joint clicks, it doesn't make it a manipulation. What it makes it is a click. But a manipulation is an intentional effort to move the joint by high amplitude, low velocity, high velocity, low amplitude thrusting, or any thrusting come to that. And but it's got to be intentional. If it clicks because you're mobilizing, it clicks. It's not a manipulation. Is that okay, guys? So yes, you do mobilize it because it's causing a problem. All right. That was Kelsey, who doesn't seem to be there. Okay, Libby, I have a few questions for the week. When assessing cervical mobility, what position you do it in? What do you find for best for passive? This is really what you'll find in the class. It's a bit pointless me showing you this. You've got videos of this anyway, but I do it in supine. The motion of the cervical spine you described makes sense, but I'm having a hard time visualizing them on my own. Can we see these with a spine model, either on a Zoom session or if you have a good link to a video? Well, there are no good videos that I know of that diagrams this. The trouble using a spinal model is you've got very small movements and very small joints. I'll draw this again though, okay? And you can ask me about it. Are these movements in the spine considered coupled? No. Coupled movement is when I side bend and it rotates, or when I rotate and it side bends. These are coupled together. This business with testing for flexion and extension, side bending, flexion and extension isn't a coupled movement. This is abnormal flexion or extension. So the hypomobile joint becomes a new axis of rotation and it alters the way this moves. So you're not doing coupled movement. It happens to side bend and rotate when you do this because the axis is wrong. So anything you might have learned about the way these segments couple doesn't apply here. Is that okay? Coupling is when you're talking about side flexion that couples with rotation, or rotation that couples with side flexion. This is not the same thing by any means. Is that okay?
Yeah, that helps a lot. Thank you.
Okay, I'll draw this again though when we're done. All right, and then you can ask questions.
I can post, I think I have 3 videos, one of Jim with a skeleton, I think one I did just going through these joints, and one of an expatriate who did one. And I'll post them, but if I send them in the email to you, they will likely hit your spam folder. So I'll email you and I'll post them in a file at the top of the page for you, okay? And I'll move it down. So I'll email you when I have those links posted. Then you can really go to the page and get them.
Yeah, you really need a diagram though. You know, it's all right, all very well. The models don't move enough. And even if they do, it's really tough to see this. So I will do another one of my excellent drawings.
Yeah, I mean, once you do the drawing, Jim, it should be really all clear.
Yeah, absolutely. Do you know, I was teaching a class here a couple of weeks ago, and I drew the vertebral basilar system for them, and this girl said, "Is there a better diagram?" Well, you cheeky cow. No, they're fucking not. All right, so if you just look at side flexion, now you're looking at this from the back, all right? So we side flex. So what you get then is the facets moving up and down. So the left one goes into extension, the right one goes into flexion. Nothing's happening with the U joint. We can model these as 0 degrees of gliding with, sorry, no, I'm getting ahead of myself, sorry. Now on side flexion, this one goes down and that one goes up. And you're left with this. So you get a curvilinear translation in the opposite direction to the side bending. Does that make sense? If it doesn't, somebody say no. Like if anybody's not sure about this, say no now. All right. Are we good? Okay. Now, if we look at flexion extension, what you have is this. Flexion, you have an upward glide of the facet joint. The unconvertible joint is there. So if we're looking at flexion extension, we can model that. We can approximate the movement to a spin. All right. Now, it's not a pure spin by any means. There's an anterior translation across the disc. There's less if you do it actively, more if you do it passively. But for our purposes, we can approximate this. We can leave out that translation and just approximate it to a spin. Is that okay? So we'll say there's no gliding occurring at the unconvertible joints. Is everybody okay with that approximation? Okay. So we combine them. There's our facets. There's our unconvertible joints. We'll do left side flexion again, but this time we'll do it with flexion. So if I flex, you get this sort of thing happening. Yeah. No movement of the facets. I then side bend this. Now, these two are going to do exactly what they do there. The translation is going to be that way, but these do something different. This facet simply has to move down towards its neutral position. It doesn't get in a neutral because it's flexed, but it moves away from the barrier. Now, this allows this joint to move further that way. So you cannot fully flex both or extend both facet joints simultaneously. One has to be unflexed or unextended, and the other one can then go to its full range. Is that all right? And this is why. If I bend my head all the way forward, I'm not fully flexed, so I can still do that, which means this one has to flex more. Is everybody okay with that? That means of all these joints, if this one can't glide down, up, it'll block side bend and translation. If this one can't glide down, it'll block side bending and rotation. And if this joint can't glide up, then that will block side flexion, inflection. But this joint can't, because all this has to do is come away from the barrier and move to a more neutral position. Is that okay? That's why this one is not the problem. Are you good with that? This was, whose question was this? This was Libby and I think Caleb. So is that okay for you too?
It definitely helps. It takes some time to chew on a little bit.
What are you having problems with?
So essentially, you're just saying that the left facet, you can't, that's not the problem because you're really not assessing it because it's never getting to a true end range.
Yeah, it's never getting to its barrier. Yeah.
It's never coming into extension.
Yeah,
okay.
Even if it was completely hypomobile, it wouldn't make any difference.
Yeah.
Because it's like basically you flex, you wouldn't know this isn't flexing unless you palpate the transverse process, which is not what we're doing. But even that, this one still has to be able to push its barrier. So even if this was completely fused, this wouldn't be the problem. Still going to be that one, or these two, or muscle. Now you actually don't know if any of these joints are affected. This could be a muscle holding it. And the only way you can know that it is one or more of these joints is to glide the joints. So if you're coming in there and it'll be a lot easier when you actually do this, but if you're coming in and doing the translate side bending inflection extension plus a translation, you'll feel it's off. It's not moving. It's just not moving. That could be muscle or it could be the joint, same as anywhere else. The only way you're going to differentiate that is either do some wobbles on it, hold, relax, and then retest it. But more effectively would be to go in and test the joints.
So the end field on those are going to be regardless if they're muscle
glides,
or joint?
Yeah, the glides are going to be bad. Yeah.
Right.
Okay, but it's no different from any other joint. Might as well do extension while we're at it. So we're going to do left side bend again, but this time extend it. These ones move down. Yeah, nothing's happening at the U joint. And then left side bend. This one has to be able to push its barrier. This one has to be able to go down. That one has to be able to go up. And this one simply goes back to a more neutral position. So the one it can't be is that right joint. Of all the things it could be, that's the one that it can't be. So you can consider these tests as PIVMs, P-PIVMs, or you can simply regard them as a screen. to help you pick the segment and the potential joints that you need to test. So you can look at them either way. Probably the most consistent way of looking at this is that this is the P-pivum, followed up with PAVMs if it's hypomobile. This is really fast. This is fast, and it's the most accurate way I know of doing this. All this stuff where you feel flexion, extension, and side bending, I've never really found anybody who does that terribly well. Certainly not at your stage of training. I've never found anybody who does it well. I've never found any manual therapist who has found the other way of doing it that keeps on doing this. I don't know. I just never found it. This stuff works extremely well. It's fast and it's accurate, I think. And what even more, I can actually manipulate this without looking at these joint glides, because what I can do is I can manipulate the translation. Now, I hate that technique. I don't do it well, but it's doable. So I put them into extension in this case and then thrust on this translation. It's not easy because you have to really stay on the end field. If you come off the end field at all, nothing happens. But you really got to stay on the end field when you're thrusting on it. But you can actually do it. Even if you screw up and you're not sure what's going on with the PAVMs, you can still do this translation as a minute. And the only time it won't work, provided it's done perfectly, is if muscles holding this all together. And before you do that, what you do is hold, relax, or wobble it, see if you can get rid of the tone that might be causing it. You're going to love this. I guarantee it. You're going to love this way of testing. Is that okay?
Yeah. Does it, do they have to be able to fully flex in order for that to apply? Like when you do the flexion and side bend?
It helps. The more flexion you get, the more extension you get, the better it is. Now, you're not going to have, when you're doing flexion, you can flex a whole lot up and do it in one go. When you do an extension, that's not my advice, is don't do that. Lift each vertebra up in turn and drop it down and pick up each one. It tends to get over that problem. But if you've got somebody with really severe pain, where you can't get any movement out of them at all, first off, it's unlikely that this is a segmental dysfunction anyway, so there's no point in doing it. And secondly, even if it is a segmental dysfunction that's extreme, that might be really inflamed with multiple other joints, motor vehicle accidents, you really are not going to do any manual therapy treatment on them to move joints around. You might do it to reduce pain, but you're not going to do it to actually move the joint directly. So if you're getting that much pain where they can't get enough flexion extension out of this, you probably don't care about it anyway. Okay. Jenna, what was that about the disc? Don't make me look up mute chat, it screws everything up. I think that was you, Jenna, wasn't it?
That was Michelle.
Oh,
She's
Michelle.
asking about a herniated disc in a 30, 40-something-year-old patient. You know, what when they say it is an extruded disc, what are they actually referring to as far as the material?
Externalization of disc material. It's really, well, no, it's really not a herniation, because a herniation is the abnormal movement of one tissue through another. What you got there is a symphysis. Now, this stuff does get extruded, and it's often with car accidents, and it's more often posterior into the spinal canal than posterolateral. The reason you see this at C5-6 is because the ulnar process, it gets smaller as you go down the neck and doesn't provide that protection to the posterolateral corner of the joint that it does higher up. So you tend to see these at C5-6, but it's external. This is basically the homogeneous tissue that is a disc at that age. It's not a nucleus. But you treat it the same way. On a hope and a prayer, basically, but you treat it the same way. Much more common is stenosis, because you've got two areas of stenosis, one coming from the facet and one coming from the unconvertible joint. And I think I sent you a diagram of that, didn't I? On one of those videos. that canal gets really narrowed in the neck, much more so than in the lumbar spine. So lateral stenosis is a lot more common in the cervical spine than it is in the lumbar spine, and disc herniations are much, much more common in the lumbar spine than in the cervical spine.
And so like this patient with the extruded disc, you're not really talking about nucleus material as you would be in the lumbar spine. This is really, as you said, like the homogeneous disc material there. I mean, it can be small fragments of that, what's left of the disc. Nucleus content. So it's a little different content.
It's a totally different way of degeneration, completely and utterly different to the lumbar spine. And I'm hoping that nobody's ever going to ask me how the thoracic disc degenerates, because I don't think anybody's done any work on that. It dries out basically, but I don't think it does either what the lumbar does or the thoracic or the cervical does. But the cervical disc is completely different. You lose height with the cervical disc, it fissures, and there's no nucleus. Totally different. Yeah. You got anything else? That's it for the questions.
I have one that's a little off topic from today's question so far, but just when I feel like I get a ton of referrals for vertigo, and in my inexperienced neck training previously, I would have just tested people for like BPPV, and if they didn't have it, say like, well, I don't really know what to do for you, or this isn't vertigo or whatever. But I mean, what techniques do we have for the, I feel like it's older patients with really stiff necks.
Are you a vestibular therapist?
What was that?
Are you a vestibular therapist, Krista?
No.
Are you a neurotherapist?
No.
Would you treat a neurological patient?
Yeah, well.
What would you? I mean, in all honesty, is that professionally ethical to treat an area that you really have no expertise in when you do have neurotherapists around? I'm not having a go at you here, but I'm making a point.
No, that's a great point. I mean, if it's something complex, certainly I would, if I thought it was out of my skill level, I would send them out. I think when it comes to this kind of stuff, we get a ton of referrals for, you know, dizziness or vertigo.
Refer them on. If seriously, you're right. You have no idea what to do with them. If you've got a vestibular patient that isn't going to get better because you do Epley's maneuver and so on, if you can't shift this thing easily, and it actually is a neurological disease process or degeneration of the labyrinth, then it needs expert rehab. And essentially, if you want to do the best thing for your patient and you can't do it, send it to somebody who can. It's really no different to, I'm not talking about a stroke, because we can all drag a stroke around, but actually rehabbing a child with CP or worrying about reflexes, or even expert rehab of a stroke patient, it's not in your area. You may have learned something about it at school, but you haven't done it. And my suggestion is you refer them to somebody who can do it. Now, if you can't refer them on because there isn't anybody to refer them to, that's a whole different animal. But if you can refer them out to somebody who does this for a living, then you should probably do that.
Krista, are you in Chicago or Iowa?
I'm in Iowa.
Okay, good.
So
I'm coming to Iowa first. That's just one of the reasons why I was kind of curious.
Yeah, and I don't know that we have, I'm just off the top of my head, I can't think of anybody specifically that I would know to send them to, but I'm sure there's something like in the Des Moines area. Here's
what we're going to do in the first cervical weekend. You know, we are going to look at evaluating the upper cranial-vertebral joints. So we think, okay, if you can rule out vestibular dizziness or vestibular cause, then we're on to, okay, we're kind of hoping this is cervicogenic. If it's just in type 2 mild disequilibrium or just feeling off-centered, we'll look for that. You'll learn how to look for that. The other thing you'll look for if they're an older patient is we'll spend a little time on Sunday looking at those cervical patients where they need a bit of vestibular integration. Now, we do a little bit more of that in the later modules with probably Eric or myself if we teach it. I know, you know, Fred used to teach it. He'd do a good bit of it. And what we're going to do is look for the profiles of those people who are those ones that you'll treat. And we'll do a little bit of the reintegration work. A lot of it comes from Gwendolyn Jaw published a nice book on this as well. We'll do some of her material and how they look at some of these cervical patients who have this disequilibrium and how this sensory integration exercises and balance stuff works quite well on these individuals. And then eventually what you want to be able to do is identify those people who don't fit in these subcategories that are appropriate for us. And those are the ones that may get moved on to a neurotherapist where there's something bigger going on. But we'll look at it from cervical origin, cervigenic dizziness, integration dizziness. Vestibular we'll touch on briefly, but I'm not going to spend a lot of time on it just because I don't have the time for it in module 2. But later on, they'll get into it a bit more. Does that make sense, Krista?
Yeah, that'll be really helpful.
So from this weekend, you should come away with the model that I just discussed and be able to kind of work through these people to say, hey, listen, it's I can go through A, B, and C, and I have a treatment strategy. And I won't have time to do a lot of the rehab stuff, but we can follow it up in post-course discussion on those who may need reintegration. That's probably what you're seeing.
Maybe, or if she's talking about old people, there's a lot of neurodegenerations there as well.
Yeah.
You know, it's a matter of deciding what you are capable of doing and what you don't have to do is the other thing. If you've got a rehab therapist there who you know is pretty good, then do it. All right. But don't spend too long. If they're not getting better reasonably quickly, you're doing something wrong. All right. They deserve better than that. David, somebody wanted to know the name of the book you were talking about.
I'm going to put it up right now. I will pull a bit from this book, and actually I was going to add the tail end of it on the rehab, and some of it is based on this model. There's all different models in cervical spine from clinical, your classification systems, and there's probably only like 15 of those if you really want to get into it. But there's a nice model of treatment they outlined in this book, which is easy to follow, and we'll use some of that on the back end if we have time.
Let me see if I can figure out what the chats are here, but it never works for me, this. I'll go right to the bottom and see where we are. Jen, are these patients more susceptible to migraine headaches if not properly rehabbed? Which patients, Jenna, the subluxations? All right, if you can explain that to me, let me know, Jenna. How do you explain all the character? Look, chiropractic terminology is their terminology. They know what they mean by it's out of alignment. You don't have to worry about it. It's not yours. What they're doing is basically saying the same thing you say when you talk about hypomobility or a jam joint. It's really not our business. It's certainly not our business to criticize their profession. I spend more time criticizing my profession than I do anybody else, with the possible exception of physicians. But that's just their language. Don't get caught up in it.
Okay, thanks.
When you treat patients that have migraines, how many are true migraines and how many tend to be? Migraines are migraines. Whatever the trigger is, migraine is a migraine. How many of these are triggered by the neck? Probably not terribly many of them. I don't know. But if I look at this, the number of true migraine patients I see is not very high that haven't been diagnosed with migraine and are cervicogenic. This does occur. Often the car accident triggers a migraine, and that may be. But the proof of it is if you manipulate the neck and the head goes away, then you can say you treated a headache that might have been a migraine. But the problem with migraine is there are so many different classifications of it now. I mean, you've even got migraine without headache. Yeah. So trying to figure out what actually migraine is, but I think there's two features to this. One is you survive them, all right? You survive half a dozen migraines. And once that happens, then basically you're probably not having a stroke. The other feature is that there is photophobia and phonophobia involved. Now, when you have a headache from migraine, which isn't always, when you have a headache from migraine, that's made worse by general movements and not by neck movements. So this is all about differentiating the migraine out from other forms of headache, such as spondylogenic headache. So spondylogenic headache is reasonably easy to separate out from true migraine, but migraine dependent on neck problems is a different animal. And all you can do is treat the neck and see what happens to the migraine. And even with a car accident, when they have a migraine after a car accident and they got a neck problem as well, you still can't say that the migraine was triggered by the neck pain or the neck. Can't even say that, because that could have been shock, almost anything. Migraines are really weird. But you treat the neck and see what happens. Okay, I don't know what that was involved with, that particular thing with Jenna. Sticky joints. Oh, is that you? No, actually, you're going to find when you examine the neck, much the same way as when you examine the lumbar spine, you will have hypomobile joints in there that are jammed up. They are not always painful. They do not always stress out other joints. But the ones who come and see you, those joints are significant. Okay, so even though that joint isn't painful, it's playing a role. You have to assume it's playing a role in what brought the patient in. So in the neck, for example, you may well manipulate and the lumbar spine, every joint hypermobility you find in that area. But that's because the patient's coming to see you with pain. How many people don't get pain from this and are not symptomatic? I don't know. You don't know because you don't see them. Okay. All right, are we correct? Okay, I'm going to just touch, I know Dave touched, and I'm going to talk about it a bit as well. Tension headache is actually quite specific as far as medicine is concerned. It's generally a band of pain that goes all the way around the head, and it feels like somebody is doing that with it. So it's not that the headache's caused by tension, it's that the headache feels like tension. So when you get a headache that is the result of tension and you're not getting that circumferential thing, it's not, strictly speaking, a tension headache as it's defined by the medical profession. It's a headache that's caused by tension, and that may well be from the neck, or it may be because of anxiety or whatever else they get. But a tension headache, I don't know that it's often classified as part of migraine sometimes. I don't know if that's correct or not, but it's often stuck in there. And I'm not sure that anybody really knows what's causing it. So this is a problem with classification. Again, what you do is anybody coming in with neck pain and a headache, you treat the neck. Providing the headache isn't a dangerous headache, you treat the neck and see what happens. And don't worry about the classification. Is that okay? Pragmatics.
Well, Jim, I got a question, follow-up question on that. So if like if the headache's like, say it's originating from like a trigger point as opposed to like a cervicogenic like joint, would your treatment still be the same or would it be different?
No, look, there is no such thing as a trigger point. There's no such physical entity as a trigger point. They've dissected these out. Occasionally those trigger points will become slightly necrotic, but that's over time. The actual trigger point has no physiological existence. This is hypertonicity of the muscle, which almost certainly is coming from the neck. So I don't think it's fair to say the headache's coming from the trigger point. They're both coming from the neck.
Yeah, that makes sense.
You okay with that? Yeah. Now, okay, when you're testing the glides of the segment, you're testing the segment joints. You're not testing the whole neck. Okay, you'll see this when you do it. It becomes a lot more clear when you're doing it. But this is all segmental examination when you're looking at glides. Okay, I'm not sure what that is. Maggie, the segment example of C5-6 spine is most common. It can also be done in seated. Okay. Actually, the joint I find, the segment I find to be most dysfunctional, most commonly dysfunctional is C2-3. And it's almost always a U joint. In fact, to me, did some anatomical work on this, and he found that the U joint, which makes sense, the U joint degenerates 7 or 8 times faster than does the facet joint. Now you've got to remember as well, the U joint is actually built to jam up. The lining of this joint is fibrocartilage. There's no hyaline in there at all. This is rough fibrocartilage where the disc is actually split. So these things are going to catch on each other. And I find them in fact, I find them so much more common than facet joints that every time I find a facet joint now, I go, oh God. And then I second guess myself and really look at it carefully. Otherwise, nearly everything I find is unconvertible joint. When you manipulate these things, the noises they make is horrendous sometimes. It's not like the little discrete pops of a facet joint. Which one is a wide receiver? Okay, we talked about that. What's the name of the book you just mentioned? And that, am I remember right, did we talk an elderly arthritic neck may not respond well to grade 2 to 3s. If they're coming in for neck pain, I would typically improve posture, strength and posterior, work on DNF training. Is there anything you would do for the cervical spine? Actually, you know, the way I look at it, generally speaking, you've got about $10,000 worth of equipment for reducing tone and pain. I hate doing mobilizations. I will stick a muscle stim on or an IFC or something else to save me from doing it. But I don't know. This is the first time I've heard that old people don't respond to mobilization. Dave?
Yeah, no, I mean, I didn't know if that was something that you had mentioned in passing here, but no, it would really be case dependent on me. I'm not as adverse to mobilizing as Jim is. I'll use it for graded mobilization, proprioceptive input. Yeah, I don't do it in high dose because you can inflame them.
Yeah, I do all that on the machine. I don't really see where the problem is with doing mobs on an old person.
Mm-hmm.
You know, actually, a number of old people I've manipulated, and they respond well to that, perfectly well, providing they're suited for it. I haven't got a problem with doing manual therapy on an old person. I'm not sure where that came from. Who was that?
Now, Marissa and I had talked in the past about somebody who's inflamed. If it's an inflamed joint, then I'll tend to be, if it's acutely inflamed, then I'm probably not going to mobilize and irritate acutely inflamed joint. But that's not the person came in with that.
Yeah, but that's not old people. That's an acutely inflamed joint.
That's not old people in general.
Okay, actually, this may be language again. Marissa, are you talking about an arthrotic neck or an inflamed neck?
Can you hear me this way?
Yeah.
Mm-hmm.
Okay. I was talking about an arthritic neck. With
That's inflamed.
Dave, I do had an inflamed. No, well, the one with Dave was an inflamed joint, but just in general, I may have misunderstood. I thought we had heard, or I thought we had talked earlier at one point. I don't remember if it was a video or Zoom, that arthritis doesn't respond well to those grade 2, 3, and that's what I've usually done. So I just wanted to clarify and just make sure I wasn't off.
Okay, yeah, if the joint's inflamed, your best bet is to try and do something about the inflammation. This is chemical, and your mobs might give them some relief over the short period, but as soon as they start moving again, it's likely to be worse. So it doesn't really matter whether we're talking about a spinal joint, an old person, a peripheral joint, or a young person. Try to get rid of the inflammation. Everything else is secondary to that. It's a chemical problem. Treat it chemically.
Okay, makes sense.
Okay, that's it, guys. Oh, that worked out well. All right. So next week, have a good one.
Thank you. Have a great one.
Thanks.
Okay.
Bye.